Hi, everyone. I'm Holly Lucen, a PT at Johns Hopkins Hospital, the Children's Center in Baltimore. And on behalf of my co-moderator, Karen Babcock, who is an RT at Johns Hopkins, we would like to welcome you to the last workshop of North American CF Conference. Today, we're going to be talking about a few different things because this is kind of a hodgepodge workshop session. We have something on nebulizers, we have a wellness program, and we have a program about home spirometry. We have some good news and bad news. Bad news is we did lose two of our speakers with the date change for conference. The good news means that there's plenty of time for questions and discussion. So please make sure you put all your questions in the Q&A so we can address them at the end of each speaker. So the first person I'd like to introduce is Courtney Lynn. She is working out of Children's Hospital of Colorado. She is a psychologist on their CF team, and she's going to tell you about a wellness program called Unite to Thrive. Welcome, Courtney.
Hi, my name is Courtney Lynn, and today I'm going to be presenting on Unite to Thrive, a virtual wellness intervention with physical therapy and psychology. I'm presenting on behalf of myself, Abby Good, the physical therapist at Children's Hospital Colorado, and Andrea Villalobos, one of the psychology students at Children's Hospital Colorado. I have no relationships to disclose related to this presentation. So for our agenda, today I'm going to give a brief background of Unite to Thrive. I'm going to mostly focus on discussing outcomes, lessons learned, and then some general conclusions. So myself and the physical therapist noticed a variety of things happening at the height of the COVID-19 pandemic. So we saw increases in anxiety and depression, a lot of social isolation among our adolescents with CF, and a lot of deconditioning in their bodies. We also noticed decreased physical activity. There weren't as many recreational opportunities for our patients, and an overall low motivation to participate in activities and wellness strategies. So out of this, we created Unite to Thrive, which is a 4 to 6 session wellness group for teens with CF. We've modified it from originally 6 sessions to 4 sessions based on some feedback, and I'll show you that in a little bit. So each session had a physical therapy content and had some psychology content. So we had a session on mobility and values and goal setting, a session on yoga, breathing and relaxation, Pilates, and mindfulness, a session on strength training where we tied that with diffusion from thoughts, and a session for HIIT, and we tied that with acceptance of feelings. And so Abby went into a lot of detail about the content of our intervention in her presentation on November 4th, and you can see the details for that presentation below if you're able to go back and watch and learn more about some of the content that we discussed. So we gave some questionnaires pre-intervention, which included the CFQR, which is the Cystic Fibrosis questionnaire revised. A lot of you are probably familiar with that one. And we also gave the child and adolescent mindfulness measure because we were really focusing on mindfulness and relaxation as part of some of the psychology content. The participants engaged in the intervention, and then we gave the same questionnaires post-intervention, as well as eliciting some qualitative feedback and some feedback on feasibility and acceptability. So, like I mentioned, a lot of you are familiar with the CFQR, and we were mostly interested in 4 quality of life domains, which included physical functioning, vitality, emotional state, and social limitations. So that's where we focused most of our energy. And on the CAM, this is a measure of present moment awareness and non-judgmental, non-avoidant responses to thoughts and feelings, which really went well with some of our techniques that we were teaching, including some acceptance and commitment therapy techniques like acceptance of feelings and diffusion from thoughts. This was a 10-item measure with a 5-point Likert scale, and higher scores were indicative of greater mindfulness. Some sample items on the CFQR: you felt energetic, you had difficulty walking as fast as others, I get together with my friends a lot. And on the CAM, some sample items: I get upset with myself for having feelings that don't make sense. It's hard for me to pay attention to only one thing at a time, and I get upset with myself for having certain thoughts. So we had 3 cohorts participate in the intervention. The first cohort lasted 6 weeks with 2-hour sessions. There were 4 girls ages 17 and 18 years old. Based on their feedback, those sessions were very long, and 6 weeks was also a long time. So we modified for cohorts 2 and 3. So cohort 2 was 4 weeks for an hour and a half sessions. We had 4 girls ages 14 and 16 years old. And the second cohort, or the third cohort, had 4 girls ages 14 years old. So looking at some of our outcomes. So for the CFQR, we had a small sample size. So you can see 9 girls completed both pre and post test. And so we looked at effect size rather than conducting any t-tests just because of the small sample size. So for the social domain, you can see there was a small effect size at 0.08, which does make sense given that the groups were during COVID-19, and so there was still some social limitations due to the pandemic. On the physical functioning domain, we had a large effect size of 0.67, which was great because we were teaching a lot of physical activities. On the vitality subscale, we saw a medium effect size. And then on the emotion subscale, we also saw a medium effect size. When looking at our mindfulness measure, again, we had 9 participants complete pre and post measures. And overall, we had a medium effect size of 0.49 for mindfulness. We also asked individuals to rate aspects of each session from not at all helpful to very helpful. So you can see for the mobility and identifying values session, most participants were finding things to be somewhat helpful to very helpful, with the majority of participants finding mobility and stretching and identifying values and setting goals to be very helpful. We also obtained qualitative feedback on each session. So for this session, participants reported they loved talking with people who understood what they were going through. They liked how it made them really think about what matters to them and really enjoyed thinking about themselves and their values. They also really enjoyed the different stretches and exercise. They liked identifying health values, but wanted this to be a greater emphasis on practical application. So we did take that into consideration. That was one of the comments from the first group. So we incorporated goal setting throughout all sessions for the second and third group. For the yoga and Pilates session, during the 4-week group, we combined yoga and Pilates together. And you can see that most of our participants found the yoga and Pilates to be very helpful. And then a range of scores from helpful to very helpful for the deep breathing exercises. Participants reported that they thought box breathing was really hard to get a hold of. They liked the yoga and Pilates because it helped with breathing and helped them to match their breath with their movement. They also really liked the session and enjoyed the assignments. They were clear and established goals. Oops, I'll go back. And lastly, they liked how tensing their muscles made them feel heavy, like a weight was lifted at the same time. And that was based on progressive muscle relaxation. For the strength and mindfulness session, most participants found things to be either helpful or very helpful. We talked about the DBT skill of emotional mind, wise mind, and reasonable mind. So they thought this was helpful to make bigger decisions. They liked that the exercises were simple and effective, and liked how easy it was to apply the mindsets to real life examples. So we used emotional mind, reasonable mind, and wise mind to talk more about real life situations. For the HIT and acceptance and diffusion session, most participants, again, reported the aspects to be either helpful or very helpful. They really liked how we noticed the thoughts that they were having, and it made them feel more relaxed and motivated. They really liked the story at the end with the demons, which is a metaphor we use from acceptance and commitment therapy for them to realize when they're feeling nervous or anxious. And they really enjoyed the mindfulness section as well as strength training and love the format. So a lot of these comments are really helpful when you know more details about the session content. So again, if you're able to watch Abby's presentation on the content, that would be really helpful to put some of this stuff into context. So their experience meeting other girls with CF, we asked them specifically what that was like. It made them realize that they're not alone. It was fine, but weird to think I met others with CF. Nice to know I'm not alone and don't have to explain CF. It was really interesting because this individual lives in their little bubble and haven't really met anyone with CF before. This individual had friends with CF, but it was nice meeting girls that lived in Colorado, so they understood more about where they live. We also asked what aspects of the sessions they found most helpful. So they thought it was helpful having a different perspective on their thinking and knowing that they wouldn't be judged. Also, the workouts were simple enough that they could do them on their own. They loved learning different stretches and exercises for their lungs. It made them feel like they were really caring for themselves. This participant enjoyed the exercise portion and learning new mental health skills. And this participant indicated the most helpful part was the fact that they knew everyone understood what they lived through, and it made them feel more comfortable. We also asked what was least helpful, but no one had any feedback for us on aspects of the intervention that was least helpful. Some lessons learned. So scheduling was very difficult for us. It was easier during the height of the pandemic when most of the participants were doing school from home or online school, which made scheduling a little bit easier. As school started to be back in session, it was really difficult to find a time that everyone could meet. And so as a result, group cohesion was a little bit harder, especially with that last cohort of girls, because not all participants were able to be consistent because they had school orientation or something related to school that they maybe needed to attend. The length and number of sessions matter. So we thought 6 weeks for 2 hours was going to be so much fun, which it was, but a lot of the girls reported that that was too long. So we shortened things as a result. And lastly, camera angle matters. So especially for Abby, our physical therapist, it was really important that the participants were able to set up their computers or tablets in a way that she could see how they were engaging in the exercises, so she could give individual feedback to help improve form and really make sure that they weren't going to be hurting themselves. Some conclusions from our group. So the first one is that PT and psychology have unique skill sets that contribute to overall wellness. I have absolutely enjoyed collaborating with Abby, our physical therapist, on this project. It's been extremely enjoyable, and we've both learned so much from each other and have been able to reinforce skills that she's taught in group, such as diaphragmatic breathing, which is something that I also teach for relaxation. So we've been able to find a lot of areas where we overlap, and it's increased our collaboration even with patients during CF clinic visits or inpatients, because we kind of know what each other's working on or what each other's skill set is. And so we're able to really capture that and elaborate on that more. Implementing a telehealth wellness group was both feasible and acceptable. And overall, patients found the group to be enjoyable and reported learning many different exercises and coping skills. So I am looking forward to being able to answer any questions or comments that you guys have during the Q&A.
Thanks so much, Courtney. That sounds like such an exciting program. I'm thrilled that there's a collaboration between psychology and physical therapy, because I think that's a big key, especially now with exercise, trying to engage not just the physiological side, but the psychology of it. What are you guys doing to sustain the program? Like you mentioned some of the hardships with school being in session now, not the end of the pandemic, but things kind of changing a little bit. What types of things are you guys thinking about moving forward in the future to kind of keep this going?
That's a really great question. So Abby and I tend to be really creative and try to come up with lots of new things that we can do. So you're right, it has been a challenge now that school is back in person for a lot of our patients, to find a time where everyone can meet and time that everyone is home, maybe without other sports or extracurricular activities. So we have tried a few different things. One thing was we tried to have like drop-in workouts, and we're still kind of perfecting that model. And right now we're focusing on offering different classes, yoga classes or workout classes during breaks and holidays. So we're trying to get patients really interested in exercise kind of during those times where they're not having school. And then we're going to be offering the group more often over the summer where there's a little bit more availability for the patients.
That sounds great. I know Abby talked about this a little bit yesterday too, that they were all females that participated, I think. Were there other common like personality traits that you noticed of the participants as far as who were the ones that you were able to successfully recruit, and what lessons or any strategies you think for getting different, a different demographic or whatever moving forward?
Yeah, that's a really great question. It's so interesting. Me and Abby have had lots of talks about this. Each group was so vastly different in personality and, how much they talked and kind of which exercises they enjoyed better even. So there was a lot of variability and not much consistency in like personality traits, I guess, across the groups. Our last group of 14-year-olds, we were so surprised. There were, different people who were usually really shy in clinic or maybe don't really enjoy going to clinic that ended up totally shining and offering support to other people in the group. And so people really kind of came out of their shell, which was really great, and started to support each other. We're not quite sure why we're struggling to recruit some of the boys. We are trying to find ways of offering incentives, so like Fitbits or other kind of physical activity trackers, and seeing if that's a way to get people to participate, even if, they're kind of loner trackers and they get to use them while they're participating in the group. So we're still kind of trying to figure out how we can get more boys to recruit.
Excellent. And you're I have another question coming in about just how you think, like, is there carryover from these kids? And you kind of mentioned it if you're talking about this group of children or teens that were a little bit shy, and then you saw them kind of coming out of their shells. Have you guys noticed anything in clinic with positive influences either on their exercise habits and behaviors, or even on their self-awareness and mindfulness behaviors that you've picked up on?
Yeah, absolutely. So we also have a bi-monthly support group that we do. So a lot of the girls who participated in this group also come to the support group. And so they talk a lot about the skills that they're using, the mindfulness skills in that group as well. And Abby also does a lot of follow-up. So she has seen some of the people that participate in the group for individual physical therapy outside of the group. So we're really able to reinforce those skills. And yeah, there's been a few girls that have really taken to exercise and have really increased their exercise and really stuck with it after the group, which has been really great and rewarding to see.
That's fantastic. Have you thought about applying the program to even younger kids, like maybe with their parents, like the preschool or early school age kids when they're doing those kind of foundational skills?
Yeah, that's a great idea. Abby just gave a presentation, a developmental presentation a few weeks ago, or maybe even last week. So we have been talking about, she noticed in the literature that a lot of exercise or activity that kids engage in and sports really starts at a young age, and parents desire to engage in those things as well. And kind of their role modeling really sets the stage for exercise throughout the lifespan. So we have been kind of thinking about if there's ways that we can do sessions with parents and kids, like you said, maybe targeting some of those younger kids to really, get them excited about exercise, and helping families kind of fit that into their schedule. So with the collaboration between me and her, we can kind of do some problem solving and identifying values with families of younger kids, and then kind of figure out how we can incorporate that exercise into their schedule as well.
Yeah, that's great. I have a couple questions coming in too from the audience. Have parents mentioned any changes in confidence with the participants, or have they noticed, or have they spoken about anything positive from the program in addition to the girls?
That's a good question. We have not specifically, I'm trying to think, a lot of the teens come to the first group was 17, 18-year-olds. So some of those girls even come by themselves to clinic appointments now. We haven't been as much in touch with the parents Abby might have more feedback from parents because I know she does PT with a lot of them outside of clinic visits, but I'm not sure about the parents' feedback. But that's a really interesting point and something that we should consider.
And then a couple people are just wanting, they want to reiterate what the parameters were for that. Like did you have target a specific age, lung function, BMI? And was this a weekly program? Is that how often you guys met?
Yep. So we met every week for 4 or 6 weeks. Only the first group was 6 weeks because afterwards they were like, okay, that was great, but it was too much. And also 4 weeks is more manageable for Abby and I as well. So we did meet once a week. As far as the other demographic variables, we didn't look specifically at lung function or BMI reported activity level. We pulled a list of patients within a certain age group and then kind of called them and asked who would be interested. We did, I know from Abby's perspective, she does evaluations at least annually. And so they had to have had an evaluation. So she kind of knew where their exercise level was at. So I'm going to take that back. Abby for sure knew more about their reported activity level and their exercise capacity. I did not. So I'm sure she kind of took that into account. But I do know that like some patients, if they were on oxygen or she felt like it wasn't necessarily safe for them to be doing some of the exercises at home without that, one-on-one time, then she would meet with them individually and not in the group setting. Some people she would meet with individually first and kind of got their exercise skills up and then they participated in the group. So for sure, she was probably taking more into account their exercise level and what they were capable of doing on their own more than I was. So she was aware of that more.
Someone else from the audience suggested, have you thought about shortening the sessions and meeting more than once a week to see if that increases participation?
That's a good idea. I think we've thought about maybe trying like every other week.
Yeah.
But that's a great idea to think about kind of fitting it all in at one time. It might seem a little bit more manageable for people if they're just committing to 2 weeks, 4 sessions rather than 4 weeks. So that's a really great idea and something that we will consider.
And then I think one final thought or question is like people really liked, I know I loved it. And I think everybody else kind of identifies with this collaboration with other disciplines. So have you thought about moving this to like not the program itself, but what other forms or types of collaborations that you guys would do with other disciplines in your clinic?
Yeah, I think our clinic is really collaborative. So we do a lot. I know I do joint visits with dietitians at home for feeding therapy. Abby collaborates a lot with the respiratory therapist and the inpatient team, creating different exercise programs. So I think we kind of naturally collaborate with each other a lot. We collaborate with the social workers. Something me and Abby have considered is so over the summer we tried, which it didn't really work out very well, but we tried to do like a sports performance group. So that was one of the ways that we thought maybe we could get more boys involved was we have a lot of like high performing athletes. And so we wanted, the summer is kind of a downtime. So Abby like ramped it up and created all these really hard workouts. And so we thought we would be able to recruit some boys that way. And as part of that, we had the dietitians come in and give we ended up having one boy who was consistent. And so that made it a little bit more challenging. But the dietitians were really open to coming in and giving more education about, nutrition and kind of wellness in general when it comes to what to eat, especially for athletes and what to eat before you exercise and after you exercise. So we have for sure thought about incorporating our dietitians into our interventions as well for some educational portions.
Yeah, I think this is just fantastic. And I love your creativity and the fact that you're trying all these outreach programs and wellness. And even if they fail, like you have to try, right? And then that's how you build and get from there. So I think it's just absolutely fantastic. We do have another question too. I know this came up yesterday, but a question about how sessions were billed.
Yep. So the sessions were an hour and a half. So Abby kind of did half of it and I did half of it, although we mixed in things with each other. So I billed for 45 minutes, which is like 1 30-minute health and behavior intervention code and 1 15-minute code. And then Abby billed 1 unit, whatever that means from her discipline. She does 1 unit for PT of a group code.
Okay.
Perhaps.
Yeah, that sounds good. That sounds great.
We did get approval ahead of time from insurance. So some people needed a referral depending on what their insurance was, but we were pretty lucky in that a lot of our patients, if not most of our patients, have Medicaid, either primary or secondary. And so that, covered everything.
And how many psychologists, are you the only one in clinic or involved with the CF clinic, or do you have a team or?
There's two of us. We have two psychologists and we have a psychology fellow as well.
And are you in clinic or do you get referred for? That's fantastic.
Yes, both of us are in clinic, which is nice.
Fantastic. Well, thank you so much, Courtney. We really appreciate you sharing this program.
Yes.
All right, and we're going to move on to our next speaker. This is Jason Suggett. He's in London, Canada, and he's going to talk to us about breath actuated nebulizers compared to breath enhanced nebulizers.
Hello, my name is Jason Suggett. I'd like to thank the organizers of the conference for giving me the opportunity to talk today. The title of the presentation is Medication Delivery of CF Drugs via Breath Actuated Nebulizer, Review of Delivery Performance versus a Breath Enhanced Nebulizer, commonly used with such medications. Before we get into the presentation itself, just a brief disclosure. I work for Trudell Medical International in a research and development, scientific and clinical capacity. So in introduction, medications to manage care of cystic fibrosis patients are often delivered via a nebulizer. Such treatment is generally easy to use and enables delivery of the typical doses needed. A breath-actuated device will reduce fugitive emissions and provide dose assurance, because dosing is not dependent on breathing pattern. However, there are sometimes questions around the dose delivered to the patient when changing between a continuous and a breath-actuated delivery device. So this study compares the two delivery modes for a number of commonly used CF medications in the home. On this slide, we compare 3 different types of jet nebulizer. So the traditional continuous nebulizer, a breath-enhanced continuous nebulizer, and a breath-actuated jet nebulizer. In the middle, we have the inspiratory, expiratory breathing cycles and showing how the aerosol is produced throughout that cycle. And on the right-hand side, we have video clips of example devices from each category. So if we look at the continuous jet nebulizer, the inspiratory, expiratory breathing cycle, throughout that, aerosol is produced at a constant rate. So that's okay when a patient is inhaling. It's not okay if the patient is exhaling and nebulized aerosol continues to be produced and emitted from the device as a fugitive emissions, or if they take a break in treatment and remove the device from the mouth. With a breath-enhanced delivery system that's continuous, then on inhalation, the amount of aerosol produced is enhanced, which is good. However, on expiration, then the nebulizer still continues to produce aerosol. Hence, you still see the fugitive emissions and you still waste medication that could have been used for inhalation. And finally, with the breath-actuated delivery system, here you only produce aerosol on inhalation. And that means you can maximize the amount on inhalation, it's still breath-enhanced. However, on exhalation, you no longer get that aerosol produced, so you don't get those fugitive emissions from the device when the patient's exhaling, and you also, if there's a break in treatment, you stop the aerosol being produced and reduce fugitive emissions that way. This means that medication delivery in this type of system is independent of the inhalation-exhalation ratio, and it's also independent of breaks in treatment. And it significantly reduces fugitive emissions. In the study, 4 different medications were evaluated: 7% hypertonic saline, tobramycin, Dornase alpha, and callistomethate sodium. Delivery was compared for each with a breath-actuated device, in this case the AeroEclipse breath-actuated nebulizer, paired with the Ombra tabletop compressor. and a continuous breath enhanced nebulizer, the Pari LC Plus, paired with the Pari Boy compressor, was compared to it. And then the medication delivery was compared using data from existing laboratory studies in terms of the performance measures reported in each study. So in terms of the results, firstly, for 7% hypertonic saline, here the data is reported as fine droplet fraction. So the proportion, a percentage of droplets less than 4.7 microns. Therefore, those droplets that are in the size range that typically could be delivered to the lungs. And the breath actuated nebulizer had slightly smaller droplets than the breath enhanced, at 80% compared with 70%. With tobramycin, here the two systems are compared, and again, the fine particle fraction showed that the breath-actuated air eclipse had slightly smaller droplets than the breath-enhanced LC Plus, around about 72% versus 64% fine particle fraction. Total mass was 140 milligrams for the air eclipse and just over 83 milligrams for the LC Plus. So more drug was delivered, and we'll come back to that later. With Oanase alpha, the performance here is reported as fine droplet mass in micrograms, and the air eclipse breath actuator system produced approximately 430 micrograms in the therapy treatment, compared with the LC Plus breath enhanced that produced around about 350. So again, a little bit more delivered with the breath actuated nebulizer system. And finally, for cholistomethate sodium, here on this study, the data had been reported as cumulative mass of cholistomethate sodium droplets less than 5.4 microns. So that mass of droplet that would likely be delivered to the lungs, and was compared over time of the whole therapy treatment. Here you can see that both systems ran at a similar output rate. However, not surprisingly, the continuous system ran out of medication sooner, and the breath-actuated system that was conserving medication ran a little bit longer and therefore delivered a little bit more drug. The summary table here compares all four medication systems and the metrics reported for each. And as I mentioned on each of the four previous pages, we can see that the breath-actuated system delivers slightly smaller droplets and also a little bit more medication than the breath-enhanced system. So in conclusion, although the medication delivery in the various lab studies was reported using different metrics, a common trend was that breath-actuated nebulizer delivered at least as much or more medication than a breath-enhanced device in each case. It's not really surprising, given that a breath-actuated system does conserve medication that otherwise would have been lost as fugitive emissions. What we need to look at is the impact of delivering that slightly more medication. And when we reviewed the safety data for the drugs themselves, we saw that the higher delivery with the breath-actuated nebulizer was within acceptable dosing ranges during development and clinical studies of these drugs. So on the basis of these studies, clinicians could select the breath-actuated nebulizer for delivery of CF medications, with the added value of a breath-actuated system offering low fugitive emissions and also improved dosing consistency. Thank you.
Thanks so much, Jason. I actually like hearing about the breath-actuated nebulizers. We're big fans of those, but the one problem, or I won't say problem, but I think the issue that we have with some of our patients, and we do work in pediatrics, is that it takes longer. So can you speak to that issue, like how much longer the medication takes to go through the breath? Actually, you said 7 minutes on the one medication. But for some people, that's because of the time burden of treatments. They like, even though it's better medication, they like to get through it as fast as possible. What information would you have for people who are facing that or are trying to convince their patients to use a breath-actuated nebulizer?
Yeah, thanks for the question. It's a great one, and I hear it a lot of the time. So I think, I mean, there's two different approaches. There's one that, you know, some of the reasons why, especially with antibiotic therapy, when you don't get the immediate dose response, I've seen so many videos and seen patients where they're sitting at home and the mouthpiece falls out of the mouth and they're okay, that it starts sputtering after 8 minutes, treatment's finished, but you know the dose hasn't been delivered. So on one hand, it's, well, okay, it will take a few more minutes longer, but you know it takes a few minutes longer because you wait until you get all of the drug. So you will be better, you'll get the right treatment, the right dose, and believe me. The other side is, I think it was on the last drug, it was the colistin, I think, that we showed on one of the charts where it showed with time. So the output rate is pretty much the same versus that particular breath enhanced. So if someone really wanted to stop after a certain time, if they were switching and it took them 8 minutes normally, after the same amount of time, if they stopped, they would at least have got the correct dose. They could stop the treatment a little bit earlier. If time was really an issue, because the output rate is the same, it will just continue a little bit longer. I personally think it's better to probably maximize the dose and get as much out as possible, because it's not going to overdose. But if someone was really concerned about the time side, if you did want to curtail the treatment after that set time that you've been used to, at least again that you've been getting the dose all the time you've been inhaling.
I think it's interesting because I think it's the selling point, and sometimes it's not the selling point, because the parents and some kids or teens that want to get all the medication they do, that's the reason they want the breath actuated. But then sometimes when they're sitting through it, it's taking longer for the kids more than the parents, then they're pushing back a little bit. So thank you for that response. We have some questions from the audience too. Why with different medications did you use different measures, like the fine droplet mass versus the fine particle fraction? Yeah, it's not, if we'd done the study prospectively in the lab, all at the same time, we would have designed the metrics to be exactly the same. So it's a limitation. So we went back to use, I think on the slides it has the references for previously presented data, and they all have some reflection on drop. So the thing that obviously affects drug delivery to the lungs is the droplet size. So is it small enough to get to the lungs, and how much comes out? So, but we did have some, admittedly, that were looking at total mass. Some were looking at fine particle mass. So yeah, I accept the criticism in terms of a study, in terms of more robustness. If we'd done it prospectively, we would have gone back and repeated all of that work rather than referring to previous studies. And some more people were asking about some of the other studies too. How does the higher delivery of the drug with the ban relate to other outcomes like FEV1, number of exacerbations, hospitalizations? Is there any significant difference in these outcomes when comparing it to other nebulizers? The short answer is that I'm not aware of any direct comparisons for these particular drugs. There's been studies with other medications with breath actuated versus continuous, where they have shown in terms of some pneumonia outcomes and readmissions a difference when using a breath actuated device, more so in the ER setting. For in this case, then I think if patients were using the breath enhanced nebulizer perfectly, so these were lab studies, if they were doing that 1 to 2 IE ratio continuously without any breaks all the way to completion, that versus the breath actuated, I'm not sure there would be tons of differences. Okay. But in reality, we know that people don't breathe at 1 to 2 IE ratio. The IE ratio can change with disease progression or the severity of the disease, or even taking a break in treatment. If you're sitting there for 10 minutes, how many people are continuously inhaling, exhaling? So I think in a perfect situation, probably not a lot of differences. In real life, I haven't got the reference, I haven't done the direct studies, but you got to believe there would be a difference. Yeah. Someone else just brings the comment up too about people with lower lung function, so like less than 30%, that sometimes the bans can be exhausting. I don't know if you have any commentary on that. That's obviously why they're not used for very young children, because you need a minimum 12 liters per minute inhalation flow rate to actuate them. So it needs some effort, which is not ideal for very young
patients, but it's a 12 liters per minute inhalation flow. So it's not so high, but yeah, recognize there is that flow rate burden to overcome in order to generate that inhalation.
And then just an aside note too, people would like you to maybe list some of your references. I don't know if you could put that in the chat for people or something for some of the studies that you've done.
Yeah, have a look. I hold my hand up if they're not there, but I thought at the bottom of the slide, each slide, there was the reference. But I
don't know if they're looking for more information is what I'm thinking,
sure.
like just references or even your contact maybe so they can get in touch with you because, you're an expert.
I'd be happy to share the actual presentations and posters from those references for anyone who's interested in getting into some of the detail on those things.
We have a few more questions too. Can you use Toby through tobimycin through the ban, or do you still do it just through the peri? Someone is asking.
Well, the tobimycin data that we generated in the lab there was using Toby.
Okay.
So I know there's different brands of the tobimycin, and that's where I'm careful here to say that this is data that we presented to show the dose. If you look on, so the drug product Toby in its leaflet, it may mention use of specific nebulizers and compressors. So it still is a decision of the clinician which nebulizer, which compressor to use. But the data that was shown there for tobramycin was actually Toby itself.
Gotcha. Does the ban withstand the cleaning and disinfection methods, or do you clean that differently than other nebulizers? There seems to be a lot of questions in the Q&A about cleaning and disinfecting.
I'm not aware of any. So this is the we used called the Aeroclips XL, which is a 6-month reusable product. So it's single patient but 6 months reusable. I'm not aware of any differences in terms of cleaning between that and your typical continuous jet nebulizers. But I can, again, if someone has any specific questions on that, I'd be happy to look into the detail and reply.
Somebody else is, again, commenting on what we were talking about earlier. Any thoughts on the concept that while the dose is reported as what the bottle states, but all the research surrounding the effectiveness of the medication has been based on what the patients are actually inhaling? So do they actually need the extra?
So in clinical research, those drug products were approved in clinical studies where patients, whether it's nebulizers or metered-dose inhalers or dry powder inhalers, everyone is shown exactly how to use the device, trained on technique, and there's a fair degree of confidence about what is delivered. So whether or not it makes a difference in if someone is using a device properly and continuously, and the extra, I think I was showing maybe 20%, 30% extra delivered with maybe a little bit more in some cases with the Aeroclips, maybe doesn't make a difference. But in the real world, I don't think everyone is using the device exactly the same way as they were trained in the clinic without breaks in treatment. And when you're not using something like albuterol, when you know if it's worked or not, and you're relying on just, I've taken the treatment and I'm assuming it's got there, that's when it can have an impact, in my opinion.
Okay. And I think there's a couple other questions about this, but I think you addressed this in your talk as well, just about you tested these because people are still concerned that that's how they were tested with these other nebulizers, that there might be too much medication or you might over-medicate, but your studies are showing that it's safe, that they're not going to get an overdose of medication.
If you look at some of the literature in terms of for those drugs, what was tested during clinical development, how it's been reported. A lot of these drugs are given IV infusion as well. And you look at the doses when it's systemic, they're not anywhere near the toxicity levels. So again, that's not me saying that someone should use something off label if it's named out on a leaflet somewhere. But if you look at the research in terms of the doses that were used clinically without any side effects, that amount of difference doesn't appear to be significant, in my opinion.
Okay. And do you find that it's hard to shift people away from another nebulizer when they're more accustomed to that to start using the breath actuated?
I think it comes back to your good point earlier about if someone's familiar with the nebulizer and if it can do the treatment quickly, and I know treatment burden, the amount of time treatment is really significant for CF patients. So that aspect is a challenge. I think when people have used them and are used to using them, and I see a comment about combining therapy. So if you're maybe combining the nebulizer with an airway clearance device, so like the Aerobica and AeroEclipse, then it makes it much easier to get people to convert.
Yeah, that's how we sell it too. Like they can get, because a lot of the other ones we have, at least in our clinic, we can't use with the nebulizer. Like our acapellas and other things we don't have the other, there's one that you can use with that. But so this is a selling point that they can do that with that.
There was a paper, it was presented at, I think it was NACFC 2 years ago, the last face-to-face one, where we looked at gamma scintigraphy lung deposition, where the drug was fed through the, I think it was, so if you put the AeroEclipse at the back of the Aerobica and then compared the lung deposition with nebulizer alone with nebulizer connected, and it was virtually identical lung deposition. So at least it gives the confidence that you can combine the therapies and you still get the right or the same amount delivered to the lungs.
That's great. I'm looking to make sure I didn't miss any. There's a couple of questions that were similar. So let me see if there's any others that I need to ask you. Again, though, if anybody has questions that weren't addressed, we can always come back to Jason too at the end if there's something that I'm missing here. I think we got pretty much everything. I also forgot to mention that he works at Truedale Medical International in your introduction. So thank you so much for speaking with us today, Jason.
Thank you.
All right. Our next speaker is Patricia Allen. She's a respiratory therapist at the University Hospitals Cleveland, Rainbow Babies and Children's, and she's going to talk about the implementation of a standardized home spirometry program.
My name is Patricia Allerton, and I am one of the respiratory therapists on the CF team at the University Hospitals Rainbow Babies and Children's Hospital in Cleveland, Ohio. The development of our home PFT program at Rainbow was a team effort, and I feel honored to present the results of this work to you today, entitled Implementation of a Standardized Home Spirometry Program. There are no relationships to disclose related to the presentation. The objectives of this presentation include introducing a few interventions that produced increased use of the home spirometers by the people with CF that receive their care at our clinic, presenting data that demonstrates meaningful use of the home PFT results by the providers, providing evidence that standardizing a home PFT program can result in the collection of quality home PFT data on which clinical decisions can be made. As was the case with all of you across the country, the necessity of a home PFT program presented itself in the middle of the chaos caused by COVID-19. And like many of you, we worked quickly to move a home PFT program into motion with the intention of building a program that could possibly become a long-term sustainable entity beyond the end of the pandemic. The early months of the project were very task-oriented and time-consuming. However, it was during this time that we recognized the need to address the underuse of the device by individuals with CF and the underuse of the test results by our CF team. I am sure that many of you were feeling the same way we were. How are we going to pull this off? So we started with PDSA cycle number 1, and this might look familiar because many other CF centers were building a home PFT program in a similar manner. And a few months into the program, we started developing interventions to address the issue of minimal use and resistance to the program. We were also setting expectations and developing standards for the home PFT program. 2 of our interventions were, number 1, an individualized home PFT action plan to be given to each person with CF who had an established baseline FEV1 on their home spirometer. We also implemented sending reminder emails to each patient to perform a home PFT for their physician prior to each virtual visit. So we were working the process, but continued to encounter the same issues as many of you across the country, with individuals not responding to phone calls and/or emails, and experienced several no-shows for virtual visits for home PFT education. So we were gathering all these test results and were we using them? Were we using this data? What more can we do to encourage our patients to use their home spirometers on a regular basis? So these questions and many more brought us to PDSA cycle number 2, which started in February of this year and is currently ongoing. In response to the continued minimal use of the home spirometers, we incorporated the process of identifying individual home spirometry needs into our weekly chart review. This allowed us to track where each individual was in the home PFT process. For example, do they need to schedule their education session? Have they established a baseline FEV1 on their home device? Do they need to bring their device to clinic to practice their technique? Are they ready for a home PFT action plan? Do they need an email reminder for a virtual visit? And because at this point, because we had such a good response for the reminder emails for virtual visits, moving forward, we decided to send emails to everyone who had not yet performed a monthly PFT each month. We continued to study and track our data with the focus on meaningful use of the test results. And we developed a patient survey to obtain feedback from the patients and their families. We were also working with our directors to assess long-term sustainability of the home PFT program. This is an example of our PFT program workflow process describing the responsibilities of the CFRTs and the PFT lab RTs. This is included on our poster number 259, if you would like to take a closer look at that. This is a bird's eye view of where we stand as a CF center with our home PFT program. 294 total patients, peds and adults combined, 260 of those that are eligible for a home PFT device, 233 who currently have a home spirometer, 155 of those who are educated and transmitting test results to the dashboard, 78 who still need to schedule an education session, and 52 patients who have met the requirements for and have received a home PFT action plan. And here's the example of the home PFT action plan. This plan is prepared for each patient after they have met the requirements of establishing a consistent baseline FEV1 on their home device. The plan is meant to be a guideline for the patient to refer to when performing PFTs at home. It is also a formal reminder that it is an expectation to perform at least one PFT per month and/or with symptom changes. So let's begin to look at our results and let's see, do we have evidence that our interventions are working to increase adherence to the protocols incorporated in our home PFT program? The bar graph displays the assessment of the home PFT action plan intervention, which revealed that 54% of the patients with a home PFT action plan were at least 50% or better with their compliance to the expectation of at least one PFT per month. And in our patient survey question regarding the action plan, 78% of those that responded found that the home PFT action plan was helpful. And in taking a look at the email reminder interventions, the bar graph displays the results of the number of home PFTs performed within the month of the reminder email. The blue bar indicates the total number of email reminders sent to the patients. The orange bar indicates the number of people who performed a home PFT after the reminder. And the gray bar indicates the total home PFTs performed that month. The pie chart displays the results of one of the questions from the home PFT patient survey. How helpful do you find our emails reminding you to do a home PFT? And 55% of the patients found the reminders to be helpful. The graphs on this slide show a comparison of the email reminder intervention, the reminder for a virtual visit versus the reminder for a routine monthly PFT. The left pie chart displays that 71% of the patients performed a home PFT prior to their virtual visit after receiving a reminder email. The pie chart on the right shows that 41% of the patients performed a home PFT after the reminder email for a routine monthly home PFT. The interventions of the home PFT action plan and reminder emails proved to be effective in increasing home spirometer use. The average monthly use of the home PFT device from May of 2020 through February of 2021 was 32 per month. And in March of 2021, when the interventions began, through August of this year, the monthly average has increased to 42 per month. In our quest to assess meaningful use of the test results from home PFTs and to address the perceived underuse of the home PFT results by our team, we took a retrospective look at the number of home PFTs associated with patients that were on IV antibiotics at home. We found that 53% of our patients had performed at least one PFT in association with their in-home IV therapy course. We were also pleased with the response to the patient survey. Have you contacted the clinic because of changes in home lung function tests? And 16% of those that answered the question in the survey had contacted our team because of a change in their home PFT results. These next few slides include trends of pulmonary function tests taken from the ambulatory EMR and confirm meaningful use of the home spirometry test results. The PFT results with the gray cloud are tests that were done in the PFT lab, and the PFT results without the cloud are the in-home PFTs. The first example shows PFTs associated with in-home IV therapy. In February of this year, the patient performed a home PFT because she was feeling sick and was experiencing increased cough and sputum production. In-home IV antibiotics were started, and she was back to her baseline FEV1 by early March. The next example is that of an adolescent who decided to stop all inhaled medications and airway clearance therapies because he felt so good on Trikafta. I'm sure you've heard this story. He did his first home PFT in July that was much lower than his baseline, and we were not sure if it was real. He did a test in the PFT lab in early September that confirmed the results on the home device were correct. He is restarting a home therapy regimen. The first patient in this example of the meaningful use had undergone breast reduction surgery in early June of 2021. By late June, she was experiencing increased cough and congestion and was treated with an oral antibiotic in conjunction to her daily therapies at home. We continue to follow her PFTs at home, and you can see that she is slowly getting closer to her baseline FEV1 of 47%. The second patient in this example is that of a college student that had stopped therapies while away at school. She performed a home PFT prior to a virtual visit in March, and the FEV1 was 46% of predicted, much lower than her baseline of 66%. However, the patient convinced her physician that the device was not working and to disregard that test result. I looked back at the results again, and the test was acceptable and repeatable, met ATS criteria. There were no mistakes. I thought it was a good PFT. So I called and emailed the patient several times to try and schedule a coached virtual session with her. She did not respond. And it's very sad to find out that a month after this PFT, this patient was admitted to the PICU. The patient in this example followed her lung function at home during her pregnancy. She had been experiencing increased cough and mucus production in early April. She increased her respiratory therapy sessions at home, but her PFT continued to decrease. In late April, she and her physician made the decision to treat with IV antibiotics, and her FEV1 returned to her baseline. She was able to stay home through her pregnancy because of this home PFT device. I'm totally shifting gears now, and I'd like to talk a little bit about PFT anxiety. As a team, we have recognized an increase in pulmonary function testing anxiety. So we decided to take this opportunity in the survey to ask a few questions related to this topic with the intention of this becoming a future quality improvement project. The pie graphs display the results of the 2 patient survey questions regarding anxiety related to pulmonary function testing. 50% of those who answered the survey experience worry and/or anxiety related to pulmonary function tests. And of those that responded yes to having PFT anxiety, 54 replied yes to the ability to check lung function at home decreases their anxiety. We have a patient quote from the survey. I am glad that I have a home spirometer at home when I need it, but I think doing monthly PFTs is not helpful for me. My PFTs tend to be lower on the home spirometer for some reason, so I often worry about my lung function being lower when in fact it is actually at my baseline. In conclusion, the information contained in this presentation provides evidence that a standardized home PFT program can produce results that are useful in making clinical decisions regarding the patient's care plan, reliable and consistent with in-lab PFTs for those with good technique on the home device, helpful in monitoring lung function during IV therapy at home, decreasing PFT anxiety for those patients that regularly check their lung function at home, capturing changes in lung function in between clinic visits, and empowering the patients to use the home PFT device to improve their care at home. It is our belief that implementing a standardized home PFT program and providing a home spirometer to each person with CF will be worth the investment if we can obtain regular, reliable data on which to make clinical decisions, as well as empower patients to use this data to improve their care at home. These are the references. I thank you so much for your attention and hope to see you all in person next year. Thank you.
Hi, Patricia. Thank you so much for your presentation. That was great and how you successfully are implementing the home spirometry. I have I actually want to thank you. I want to thank you for sharing about the anxiety with PFTs, because that's something I think a lot of us are well aware of, but it's real. And it's nice that that was something that that patient brought to you, that was a way to decrease the anxiety. I was wondering if you could speak more to that, about some experiences you've had, or other patients, have they've expressed that to you?
Yes, we've actually had both ends of the spectrum. We've had a few patients drop out of the program because they're so nervous at home to check a PFT, and if it's a little bit lower than what they're used to, they worry about it for a full week. And usually that situation, it's a technique issue, and most of the time we can have the patient bring their device into clinic with them, and we practice in the PFT lab and just work on a few changes to their technique, and usually they're spot on with their PFTs in the PFT lab. So, but I have 2 patients in particular that it was just too stressful for them at home. But then the other end of the spectrum, patients that were able, feel good about being able to check their pulmonary function tests at home, and that gives them they just feel secure that they, yes, I'm still where I'm supposed to be. So we've had both, that it helps ease that anxiety or it makes it worse.
Yeah, that's interesting. One of the speakers yesterday, an adult with CF, actually mentioned his anxiety with PFTs in the lab and how the home spirometry puts him more at ease when he's doing his testing. So that is very interesting. Do you ever talk to patients about, because it's hard, I guess, especially during the pandemic when you might not have been able to get them in, but now that they can come in, about doing their home PFT the same day that they're in lab, so that they can see if there is a difference? Because I know we talk about trends. That was the one way I talked one of our adolescents down, is like, well, I don't care if it's the same, if you come in here and it's higher, but then you'll know, so the next time you can kind of see if the trend is there. I don't know if you use different strategies.
Yeah, and we do use different strategies for different situations. But the one, the young man who stopped doing his therapies and his PFT on the device was lower, and I did not coach that session, so I didn't see his session, but everything, met criteria, ATS criteria when you look at it in the dashboard. But then that same day that he did his PFT in clinic, we had him do it again when he got home on his home device, and it was I think it was 97 at home and 98 here. So it confirmed that, yes, it really is that, his PFT was lower and he needs to do his therapies.
2 questions for you about baselines. There's a question out there, how you established your home PFT baseline.
So the patients had to have very good technique on their home device, had to meet ATS criteria on a consistent basis with their home PFTs, and they had to be very close to their baseline PFT in the PFT lab here. So those are criteria that we use before patient gets a home PFT action plan, is that they're consistently meeting those numbers on their home device. And then, that's how we establish that baseline.
And then I have a question for me. I was just curious how you establish the 1 time a month baseline too. I'm a PT, so I'm not in the RT world, but I know that we usually do them quarterly unless somebody has an illness or trending in a different way that they would come in more frequently. So is there a reason why once a month was established? And do you think maybe that could also contribute to some anxiety if they're doing it more frequently, or decrease the anxiety because they're doing it more frequently?
Yeah, well, a couple things. First of all, the technique is different than what they're used to in the PFT lab. So if you're not doing it consistently or on some kind of a regular basis, we'll have people not do a PFT for 6 months on their home device. All of a sudden they do one and it looks terrible because they forgot, the tips and tricks that we taught them and the technique that on the home device. So that's, one reason we chose once per month. We also chose once per month because when you get a PFT every 3 to 4 months, it's a shot in the dark. It's a picture, a moment in time. A lot can happen in between there. And we're trying to change the culture within our center, both with our patients and with our team, that this is something that's a useful tool that we can regularly use and use it for trending lung function at home. A few of our physicians would like the patients to do it once per week, to really capture trends. So those are the reasons we thought we'd start it once per month and, just try to get that culture change and go from there.
And I really think your meaningful use examples that you provided in your presentation were a great example of that, and a wonderful education tools that other people can use with their centers too, of the value of the home PT or home PFT if it's done correctly. There's some questions out there too about technology. I know a lot of people have experienced in their centers or clinics difficulties with connecting in or using the app or how they're transmitting the data to their center. So we're wondering if you could speak to that a little bit.
Yeah, there were.
If any of your patients had the same issues.
Yes, we definitely had technical issues, and ZephyrX they were wonderful with helping us work through those. Of course, at the beginning, the app was being updated on a regular basis, and so there was a lot of change, a lot of good change. They did everything that we asked. I think it was Mary Lester that said we want the very best for our patients, and that's what we were asking for whenever we went back to the table with ZephyrX for, yes, can we have this, can we do that? So that was definitely an issue, but they helped us trouble through each and every one of those issues. And most of the time we were able to troubleshoot through the technical issues. A lot of times, for our patients that were successful at first and then they couldn't, the technology wasn't working right, it was usually the app needed updated or something simple like that. We did have a few patients who their smartphone just could not handle the technology and ended up getting a MicroLife instead, and are able to trend lung function using the MicroLife, which does not need a smartphone or any device.
Another sort of technology question, but someone was talking about email barriers. So you said you used emails to message to the families, and I guess some facilities have secure email and the families were having an issue with opening them up. They were wondering if you had any of those barriers or any suggestions for how to utilize that. I know we're supposed to go through MyChart, but then it becomes a problem of patients getting so many MyChart messages that they start disregarding things because there's just so much.
Right. And that is the extra emails. That's always a problem. It's that is difficult. But we have not had an issue with security, with patients being unable to open our emails. And we've had a good response with our email outreach for the home PFTs. I will say that some people, and this was in our patient survey, some people, don't appreciate getting that monthly reminder. And we would like to be able to send a text or something in that manner instead of an email. So some of our patients have let us know they would prefer a text message, and it's, doesn't get buried in an email.
I'm going to read this one because I'm not exactly sure what the GLI stands for, but somebody was mentioning that the GLI predicted values were obtained with the baseline PFTs. And if not, if you didn't use that, you'd have to readjust your results. So they wanted to know if you did use that for the home. Okay.
Yes, our PFT lab uses GLI as well.
Okay.
So we were apples to apples, which was great.
Perfect. Do you use action plans for both your peds and adults populations?
Yes, I don't think we have anyone really young yet that has an action plan. Our younger patients need coaching when they do their home PFTs. So far, we've got a few that are able to handle the technique and do a really good PFT, but we have adolescents on up that do have a home PFT action plan.
So you typically wouldn't do this on somebody who is brand new to PFTs, would not start them off with the home spirometry.
Right, no, yes.
Okay, someone was asking that question too, but you answered it. So okay. Let's see here. I'm sorry, I'm going to scroll down because you have a lot more messages. Have you handled reimbursement for the monthly PFT data? Do you use the provider portal to collect the results?
We do use the dashboard. And at this time, we are not billing for the actual use of the dashboard to the patients. Our center rolled that into the budget. So we're paying for the dashboard. It's not something that we're billing out. And that's something that's in the works. We're not sure if we're going to be able to do that. And it might be, if moving forward, we might continue to budget this within the pulmonary budget to pay for the dashboard.
Okay.
Did I answer that completely?
Yes, I think you did. I mean, there's lots of similar questions coming in. Have you used the new reminder feature on the dashboard? People are asking.
No, not yet. And we had just changed how we sent the email out. So we were in the works with that when that new feature came out. So we have not tried that yet.
Okay. Someone's asking if you do a screen prior to the PFT, the same call visit, and if you did, will that show a big difference with the PFT results?
A screen.
Yeah, I'm not sure I understood either, but trying to get to all your questions.
Yeah, we don't do screenshots. We never felt comfortable with the screenshot without the rest of the PFT. Being able to look at the entire PFT with every effort was very important to us. We wanted to follow ATS criteria with this program from the start. And when we were just getting the spreadsheet at the beginning without the flow volume loop, and then the patient just sending us their best effort, we really didn't feel complete about that, or we didn't feel like we could use that information to base decisions for care. So we didn't ever use the screenshot as far as putting that into their electronic medical record.
And is there any one thing that you've done you think that has really brought the buy-in from your patients and families that have embraced the action plan and are doing their home spirometry?
I think it's the same as everything else we do, right? It's that constant follow-up. It's the education, re-education. When they come in, we remind them. We put it, as I said in the presentation, it's part of our chart review for the following week. Who's coming? Where are they in their PFT? Do they need an education session? What do we need to do next? So we send out those reminders as well with our preclinic calls or our preclinic email, depending on the patient, and remind them to either bring it in with them to practice or whatever needs done.
Have you had any patients that are now believers more? I mean, I know they're doing it, but like, I'm really glad you talked me into doing the home spirometry.
Yes.
Are they seeing the benefit?
Yes. And, it's been fun to see patients who just experimented in completely different situations once they got their device. They were doing it before exercise, after exercise, early in the morning, late at night, just all different things. We have a few really scientific people that come to our center for their care, and they just totally took off with this and did all kinds of experiments with it. So that was kind of fun to see. But it seems like the people who are really consistent with their care, those were the first to buy into this, the home PFT program. But I feel like it's slowly taking hold, and we're getting more and more patients that are buying in and understanding this is an expectation as part of their care here.
That's great. And then I think one final question is just about HIPAA. Someone was asking if you have any HIPAA issues with texting their facility, and I think our facility as well, not allow the clinic to communicate via text.
Correct. And that we are not either. That's why, I do know that one center had purchased a cell phone to be able to send texts. I forget which talk that was in, but they bought a CF phone that they could send text messages from.
Oh, that's great.
And so I thought that was a great idea for those patients that would prefer a text message. But no, we don't have that capability either.
Okay, well, thank you so much. Again, I'm so happy that you guys are having the success you are with your home spirometry program. It seemed like a very good plan. And I want to thank you, Patricia, Jason, and Courtney for your wonderful presentations today, and for all the audience members who actively participated and submitted questions. Thank you for attending NACFC this year. I hope everybody has a great year. I hope we can meet again next year in person. And I also want to spend a special shout out to Stephanie Gamble, who was my original moderator, but also had to stop because of the change in schedule, and to Karen Babcock, our wonderful RT at Hopkins, for filling in and doing a great job behind the scenes today. So thank you, everybody, and enjoy your weekend.